Hello, everyone, and welcome back to the EP Edge podcast. I'm Dr. Sharma. This is Pulse Field Ablation Part 2. In Part 1, we stayed mostly on the engineering side, what electroporation is, why the waveform matters, why tissue selectivity is the core promise, and why PFA has been marketed as safer and faster than thermal energy. Today, we shift from physics to patients. Part 2 is a longer than usual episode. We have a lot to cover, especially with arrival of two new PFA trials, the Insight and the Pulsar. We will delve into pivotal clinical trial evidence, how the major platforms earned regulatory confidence, what the trials actually measured, and what we should and should not conclude when we see a 12-month success rate in a paper or on a slide deck. And just to set expectations, I'm going to be detailed, but I'm going to keep it conversational. If you're a nurse or an allied professional listening, I'll define terms as we go. If you're a fellow or an electrophysiologist, I'll slow down at the methodological gotchas that matter when you compare platforms. All right, let's get into it. Before we talk about specific trials, I want to give you a mental framework, because this is where people get misled. The interpretive trap is assuming that freedom from atrial fibrillation at 12 months is a uniform construct. It is not. Across the PFA programs, the studies differ in at least 5 ways that materially change the measured event rate. 1. The patient phenotype, paroxysmal versus persistent atrial fibrillation. 2. The lesion set, pulmonary vein isolation only versus pulmonary vein isolation plus posterior wall or other substrate work. 3. The endpoint definition, pure rhythm recurrence versus a composite that includes drug escalation, cardioversion, and redo ablation. 4. The monitoring density, intermittent EKG and Holter monitoring versus continuous implantable monitoring. And 5. The statistical framework, randomized non-inferiority comparisons versus single-arm performance goal designs. Let me translate a few of those in plain English. A composite endpoint is when failure includes not only a documented arrhythmia, but also what clinicians do about it, like starting an antiarrhythmic drug, increasing a dose, performing cardioversion, or bringing the patient back for a redo ablation. That tends to lower the measured success rate compared with arrhythmia recurrence alone, and it injects practice pattern variability. Monitoring matters even more. If you check a patient with a 12-lead EKG at 3, 6, and 12 months, and you do 1 or 2 Holters, you will miss asymptomatic recurrence. If you implant a continuous monitor, you detect more events. So when you see 2 trials with different monitoring, the absolute success percentages are not directly comparable, sometimes not even close. Finally, on design, a randomized trial tells you how the new energy compares with a comparator under the same rules. A single-arm performance goal trial tells you we beat a predefined bar, but it does not tell you the new energy is better than the best contemporary thermal workflows. That doesn't make single-arm trials useless. It just means we have to interpret them with discipline. With that framework, we'll go in roughly chronological US approval order and then finish with the newest wave of studies. First up, Medtronic PulseSelect, approved December 13th, 2023, built on the PULSED AF pivotal trial. PULSED AF is a global, multi-center, non-randomized pivotal study with 2 separate cohorts, paroxysmal atrial fibrillation, think self-terminating episodes, and persistent atrial fibrillation, where episodes last longer and the substrate is typically more complex. They enrolled 150 patients in each cohort for the primary analysis. Now, a key point about who they studied: patients with very large left atria, long-standing persistent atrial fibrillation, and significant structural disease were generally excluded. So this is not the sickest end of the spectrum. That matters for generalizability. The procedure itself is fairly representative of modern PFA workflows. Pulmonary vein isolation was achieved acutely in essentially all veins. and the protocol mandated a 20-minute waiting period with reassessment of entrance block, which is important. In plain terms, they didn't just touch the vein and declare victory. They waited to see if early reconnection showed up. How did they follow patients? It was not continuous monitoring. They used weekly and symptom-driven trans-telephonic monitoring, basically remote rhythm transmissions, plus scheduled 12-lead EKGs at 3, 6, and 12 months, and 24-hour Holters at 6 and 12 months. So this is reasonably rigorous for a pivotal IDE-era trial, but it is still intermittent. What counted as success? This is where the nuance is. The primary effectiveness endpoint was a composite through 12 months after a 90-day blanking period. Failure could be arrhythmia, recurrence, but it could also be cardioversion, repeat ablation outside blanking, or escalation or initiation of certain class 1 or class 3 antiarrhythmic drugs. In other words, it's not purely drug-free rhythm freedom. On results, the 12-month composite effectiveness was about 66% in paroxysmal atrial fibrillation and about 55% in persistent atrial fibrillation. If you isolate arrhythmia recurrence alone after blanking, the numbers look a bit higher. So again, composite endpoints and monitoring density drive the headline number. Safety in PULSED, AF looked strong. Serious device or procedure-related adverse events were rare. And the catastrophic thermal complications, atrioesophageal fistula and significant pulmonary vein stenosis, were not observed. They also had sub-studies. Brain MRI showed silent lesions in a minority, and imaging did not show moderate or severe pulmonary vein stenosis in the imaged subset. So how should we interpret PulseSelect's pivotal dataset? It supports feasibility, procedural efficiency, and a low major complication rate in selected populations with outcomes that look in the range of contemporary thermal results, bearing in mind the endpoint and monitoring structure. It does not, by design, answer better than thermal because there is no randomized comparator. Next, Boston Scientific FARAPULSE, approved January 31, 2024, anchored by the ADVENT randomized trial in paroxysmal atrial fibrillation. ADVENT is important because it is one of the cleanest apples-to-apples comparisons we have in PFA. It was a multi-center, randomized, one-to-one, single-blind, non-inferiority pivotal trial. Patients did not know which energy they received, endpoints were adjudicated, and the thermal comparator was contemporary, either radiofrequency or cryoballoon, with sites committed to one modality. They enrolled over 680 patients who underwent ablation, with roughly 305 in the PFA arm and 302 in the thermal arm. The population was symptomatic, drug-refractory paroxysmal atrial fibrillation, adults up to 75. Baseline risk looked like a typical ablation trial cohort, early 60s on average, moderate comorbidity, and a relatively low to moderate stroke risk score. Ablation strategy was pulmonary vein isolation in both arms with a required waiting period and confirmation of entrance block. CTI ablation for typical flutter was common in both arms. Additional non-pulmonary vein ablation was rare and slightly more common in the thermal group. Monitoring was intermittent but denser than just 2 Holters. They used weekly remote event monitoring after the 3-month blanking period plus symptom-triggered recordings, and they did 72-hour Holter monitoring at 6 and 12 months. Still, it is not continuous, so the absolute recurrence rates are still partially surveillance limited. The primary effectiveness endpoint, again, was a composite. It included acute procedural failure, documented atrial arrhythmia recurrence after blanking, antiarrhythmic drug use or cardioversion after blanking, amiodarone at any time, or repeat ablation through 1 year. So the trial measures a clinically pragmatic, was the strategy successful without needing major rescue steps, not just electrogram-defined recurrence. Results 1-year primary effectiveness success was about 73% for PFA and 71% for thermal. The difference was small and the trial met non-inferiority with a very high posterior probability. The point estimate is essentially equal, so ADVENT is not a superiority story. It is PFA performs at least as well as best practice thermal ablation in paroxysmal AF within this monitoring and endpoint structure. On safety, serious adverse events were low in both arms and met non-inferiority. But we do need to say this out loud. There was one death in the PFA arm associated with a tamponade and resuscitation cascade. There were also tamponades in the PFA arm and none in the thermal arm in the trial dataset. That doesn't mean PFA causes tamponade. It means mechanical complications still exist, and they remain a key safety frontier. Thermal had its own signal. Persistent phrenic nerve palsy occurred in a small number in the thermal arm and none in PFA. Neither group had atrioesophageal fistula or clinically significant pulmonary vein stenosis. A particularly interesting secondary endpoint was pulmonary vein narrowing. They measured change in aggregate pulmonary vein cross-sectional area from baseline to 3 months. PFA had minimal change, under 1%, while thermal showed a larger average reduction. Mechanistically, that's consistent with the idea that non-thermal energy may reduce the propensity for vein stenosis. ADVENT also had a brain MRI substudy. Silent lesions were seen in a minority of PFA patients and not seen in the thermal subset, but the sample sizes were small. For me, the broader takeaway is silent cerebral embolic events remain an ecosystem problem. Catheters, air, anticoagulation, workflow, not just an energy source problem. Now, still in the FARAPULSE ecosystem, we have Advantage AF in persistent atrial fibrillation and the manifest registries. These are not randomized comparisons. They're about generalizability, lesion set feasibility, and rare safety signals at scale. Advantage AF is an FDA IDE program in symptomatic persistent atrial fibrillation, and importantly, the ablation strategy in the pivotal cohorts was pulmonary vein isolation plus posterior wall ablation. So right away, this is not directly comparable to ADVENT's pulmonary vein isolation only paroxysmal trial. Different patients, different lesion set. The phase 1 dataset used an intermittent monitoring strategy, twice monthly trans-telephonic monitoring plus symptom-triggered transmissions, 24-hour Holters at 6 and 12 months, and scheduled EKGs. The primary effectiveness endpoint was a composite after blanking, requiring freedom from documented atrial arrhythmia recurrence, no redo ablation, no cardioversion, and no new or escalated class 1 or class 3 antiarrhythmic drugs or amiodarone. The headline effectiveness number was in the low to mid-60s for that composite endpoint at 12 months, exceeding the pre-specified performance goal. Again, performance goal met is not better than thermal. It is the strategy meets a predefined standard of effectiveness in persistent atrial fibrillation under this monitoring regime with this lesion set. Safety met its performance goal as well with a low serious adverse event rate. There are a couple of signals worth remembering because they show up across PFA programs. Coronary spasm, rare but real, and hemolysis signals in a small number. Most of the serious events in the phase 1 report were things like pulmonary edema and pericarditis. Catastrophic complications, atrioesophageal fistula and pulmonary vein stenosis, were not observed. Phase 2 incorporated implantable cardiac monitors. But here's the critical nuance. For the primary effectiveness endpoint, the continuous monitor data were deliberately subsampled to emulate intermittent monitoring. So even when an implantable monitor is present, the primary endpoint can be structured to behave like an intermittent trial. That design choice matters if you're trying to compare success rates across studies. Now let's talk post-approval safety, the manifest registries, because this is where scale helps us see rare events. Manifest PF was an early European post-approval registry with about 1,568 consecutive patients. Major adverse events were under 2%. The dominant hazards were still the classic ones: tamponade around 1% and stroke around 0.4%. There was one death, and the reassuring signal, again, was zero atrioesophageal fistula and zero symptomatic pulmonary vein stenosis reported. Manifest 17K scaled this up dramatically, over 17,000 cases. Major adverse events were under 1%. Deaths were rare. Stroke was around 0.1%. Tamponade was a few tenths of a percent. Coronary spasm showed up. And importantly, hemolysis-associated renal failure requiring hospitalization was detected. Rare, but not zero. Again, no atrioesophageal fistula and no pulmonary vein stenosis signals were reported. Then Manifest US, with over 40,000 patients across more than 100 institutions, pushed the same story into US routine practice. Overall, major complications were well under 1%. Tamponade and stroke were each about 0.1 to 0.2%. Death was rare but present. Coronary spasm was present. And acute renal failure requiring dialysis consistent with severe hemolysis in a small subset was present, again very rare. And the absence of fistula and clinically significant vein stenosis persisted. So what's the net message from the Manifest datasets? PFA safety appears scalable, but it does not eliminate procedural risk. The energy may shift certain injury phenotypes downward, especially esophageal catastrophe, but the mechanical, thromboembolic, and workflow hazards remain. And at scale, you start to see the very low-frequency, dose-related signals like hemolysis and renal injury that smaller trials are underpowered to detect. Third, in our approval timeline, Medtronic Sphere-9, the Affera lattice tip system, approved October 24, 2024. This is a different flavor of platform. It's a focal lattice tip catheter paired with a dedicated mapping and ablation ecosystem. The Sphere per AFIDE trial is randomized 1-to-1, single-blind, and non-inferiority. The population was symptomatic, persistent atrial fibrillation, refractory or intolerant to at least one Class 1 or Class 3 antiarrhythmic drug. They randomized over 400 patients with about 212 in the investigational arm and 208 in the control arm, which was a contemporary focal radiofrequency platform. Both arms required pulmonary vein isolation. But here's a key methodological reality. Additional lesion sets were very common, especially in the investigational arm. Posterior wall lines, roof lines, inferior lines, mitral lines, CTI, these were done frequently. So when you see a performance difference, you have to ask, is this the catheter or is it more substrate modification? That's lesion set confounding. Monitoring was again non-invasive and intermittent. Holters, EKGs, and telephonic transmissions with good compliance and core lab adjudication. The primary effectiveness endpoint was a composite through 1 year after blanking, including arrhythmia recurrence, redo ablation, cardioversion, and antiarrhythmic drug initiation or escalation. Results: primary effectiveness success was roughly 74% in the investigational arm and 66% in the control arm. Non-inferiority was met. The absolute difference favored the investigational arm, but the confidence interval crossed zero. So statistically, this is non-inferior, with a suggestion of benefit. Safety was low and similar between arms, and in the reported trial dataset, catastrophic complications, atrioesophageal fistula, pulmonary vein stenosis, tamponade, stroke, were not observed. There was also a brain MRI substudy showing acute lesions in a small minority in both arms, with most resolving on follow-up imaging. So the clinical takeaway for Sphere-9 is a randomized persistent AF dataset showing at least non-inferior effectiveness to contemporary focal radiofrequency, with low complication rates but with heavy confounding from extensive adjunct ablation, especially in the investigational arm. It's a reminder that persistent AF outcomes are often about the overall strategy, not one magic energy source. Next, moving on to fourth, Johnson & Johnson Biosense Webster Varipulse, approved in late 2024, built on the ADMIRE pivotal trial in paroxysmal atrial fibrillation. ADMIRE is a prospective multi-center single-arm FDA-IDE pivotal study, so again, a performance goal framework, not a randomized comparison. The population was symptomatic drug-refractory paroxysmal atrial fibrillation in adults up to 75 without prior ablation. The pivotal cohort treated was about 277 patients. The index strategy was first-time pulmonary vein isolation in everyone. Monitoring in ADMIRE is interesting because it blends consumer-style technology with traditional methods. They used Cardia Mobile 6 lead recordings weekly early, then monthly later, plus symptom-triggered recordings. They also did 24-hour Holters at 6 and 12 months and scheduled EKGs. Core lab adjudication was used, so the monitoring is still intermittent, but with higher frequency patient-driven captures than in many older thermal trials. The primary effectiveness endpoint was again a composite at 12 months, no acute failure, no use of a non-study catheter, no repeat procedure except potentially one during blanking, no documented atrial arrhythmia recurrence after blanking, no new or escalated antiarrhythmic drug therapy, and no cardioversion after blanking. The headline effectiveness success at 12 months was in the mid-70s, and freedom from atrial tachyarrhythmia recurrence after blanking was also about 75%. Safety events were low overall, with pericardial tamponade as the most common serious complication. A workflow note that's practically relevant. A substantial fraction of cases were performed without fluoroscopy, reflecting integration with contemporary mapping workflows. Interpretation: ADMIRE supports that a pentaspline PFA catheter can achieve good paroxysmal pulmonary vein isolation outcomes with acceptable safety in an IDE framework, but because it's single arm, the discipline conclusion is meets performance expectations, not beats thermal. Fifth, Abbott Volt with US approval in December 2025, and an evidence package that includes a CE mark study, 12-month follow-up presented at a major meeting, and an IDE program with acute results reported. The Volt CE mark investigation enrolled about 150 patients with 146 treated. It included both paroxysmal and persistent atrial fibrillation, roughly 70% paroxysmal and 30% persistent. And the lesion set was pulmonary vein isolation only. That's important. No posterior wall, no additional substrate lesions as a mandate. They also mandated a waiting period. Monitoring combined scheduled EKGs, biweekly transtelephonic monitoring, and a 24-hour Holter at 6 months. Acute isolation metrics were excellent, near universal acute pulmonary vein isolation with very high first-pass isolation rates. Safety events were low, dominated by vascular complications and one tamponade, no deaths, no atrioesophageal fistula, no phrenic nerve injury, and no hemolysis signal in that early cohort. All right, before we finish the Volt story, let's take a quick breath and recap where we are. Up to this point, the pattern is consistent across platforms. Acute pulmonary vein isolation is nearly universal. Safety has improved in meaningful ways, especially for the catastrophic thermal complications, but the one-year efficacy numbers look broadly similar to contemporary thermal ablation when you compare like with like. After a short break, we'll come back and finish Volt, especially the 12-month signal in paroxysmal versus persistent AF, and then we'll move into Insight and Pulsar, which are really about optimization and durability. Okay, quick break. up where we left off, let's finish the Abbott Volt story because it's a nice example of how PFA can look phenomenal acutely while the longer-term outcomes still obey the biology of atrial fibrillation. The first dataset is the Volt CE Mark program at 6 months. It was a prospective, multi-center pre-market investigation across 11 sites in Europe and Australia, 150 enrolled, 146 treated. About 70% were paroxysmal AF and about 30% persistent AF. The lesion set was pulmonary vein isolation only with a mandatory 20-minute waiting period. Monitoring was structured but intermittent, scheduled EKGs, bi-weekly transtelephonic monitoring, and a 24-hour Holter at 6 months. Acute PV metrics were excellent. About 99% of pulmonary veins were acutely isolated, and first-pass isolation was about 98% per vein, with roughly 18 PFA applications per patient. Safety in that cohort. Primary safety events were about 2.7%, and the events included 2 major vascular complications, 1 tamponade and 1 pneumonia, and importantly, no deaths, no atrioesophageal fistula, no phrenic nerve injury, and no hemolysis signal in that early cohort. At 6 months, freedom from documented atrial arrhythmias looked strong, about 88% for paroxysmal and about 77% for persistent, and the composite effectiveness success was about 86% for paroxysmal and 72% for persistent. Then we moved to the 12-month outcomes presented as part of that same CE Mark cohort. Again, 146 total patients, 103 paroxysmal and 43 persistent. At 12 months, freedom from documented atrial arrhythmias was about 83.5% for paroxysmal and about 58% for persistent. And that drop in persistent is the key teaching point. If you do pulmonary vein isolation only in a substrate-heavy population, even with elite acute isolation, the ceiling shows up again. They also reported durability signals in redo procedures. About 94.5% were free from repeat procedures overall, and among the veins assessed at redo, about 90% remained durably isolated, 27 of 30 veins. Useful, but remember, redo-based remapping is selected. It's not a universal remap substudy. Finally, the Volt AF-IDE acute dataset gives you scale. 320 patients, roughly half paroxysmal and half persistent, again pulmonary vein isolation only, no adjunctive lesions. Acute isolation was essentially universal, about 99.5 to 99.8% per vein. First pass isolation was around 92% in paroxysmal and about 90% in persistent. The workflow signal is also practical. A small fraction were zero fluoro, and a meaningful minority were performed with conscious or deep sedation, with some cases avoiding propofol entirely. Safety in that acute IDE dataset. Primary safety events were about 1.9%, including tamponades, pericarditis, a stroke, and a vascular complication, with no hemolysis or renal injury signal reported there. So taken together, Volt looks technically efficient and clinically credible, but it doesn't break the fundamental rule. Persistent AF remains persistent AF when the strategy is pulmonary vein isolation only. Okay, let's shift to what I called the latest wave, where the field is trying to optimize 2 things. First, intraprocedural durability, and second, patient movement and neuromuscular capture that can complicate sedation and catheter stability. The trial here is Insight PFA, nanosecond PFA versus ablation index-guided radiofrequency for pulmonary vein isolation in paroxysmal atrial fibrillation. And the comparator is important. Ablation index-guided RF is not average RF. It's a best practice thermal workflow. Design-wise, Insight was prospective, multi-center, randomized, 1-to-1, and non-inferiority. They enrolled 287 patients across 13 centers and about 141 in the nanosecond PFA group and 142 in the AI-guided RF group completed follow-up. Here's the methodological feature I really like. There was a mandatory at least 20-minute waiting period after pulmonary vein isolation. And if a vein reconnected during that wait, they were required to re-ablate, then re-wait until stable block was confirmed. That design makes acute success less superficial than trials without mandated waiting. Follow-up rhythm surveillance was structured but intermittent. Patients had on-site visits at 1, 3, 6, and 12 months with a 12-lead EKG and a 24-hour Holter, and they were instructed to obtain an EKG promptly if symptoms suggested recurrence. So the trial detects clinically meaningful recurrence, but it's not continuous implantable monitoring. The primary efficacy endpoint was freedom from documented AF, atrial flutter, or atrial tachycardia, episodes lasting at least 30 seconds off Class 1 and Class 3 antiarrhythmics from the end of the 3-month blanking period through 12 months. Results were the classic modern story. About 65.5% success for nanosecond PFA and about 64% for AI-guided RF. The adjusted difference was about plus 2%, and the trial met non-inferiority. Time to event estimates were essentially the same, mid-60s in both arms, with a hazard ratio around 1. Translation: nanosecond PFA matched optimized RF, but it did not beat it. And the intra-procedural durability signal is humbling. During the mandated waiting period, per vein reconnection was in the low teens, roughly 14% for nanosecond PFA and about 12% for AI-guided RF. So even with advanced waveforms and careful protocols, acute reconnection is not zero. Durability remains the central constraint. Before we leave Insight, let's talk safety. And this is where we have to be a little nuanced. The headline was no significant difference in procedure-related adverse events between nanosecond PFA and ablation index RF, and no obvious catastrophic signal in that dataset. But Insight also surfaced a few mechanism-relevant, very practical things. One was a transient ischemic type event that was felt to be consistent with an air embolism workflow issue and not necessarily the energy source. And there was a hemolysis or hemoglobinuria phenotype when application counts got very high, think tea-colored urine, bilirubin shifts, without overt renal failure. The reason I mention that is simple. It's a dose marker. It's the system telling you if you're doing too many applications, your efficiency is off. Now the limitations, because they matter for interpretation. Rhythm monitoring was intermittent, EKGs plus limited Holters, so asymptomatic recurrence can be undercounted. It's a non-inferiority design. So non-inferior does not mean equal in every clinically relevant domain, and the chosen margin always matters. And safety ascertainment can miss subclinical injury if you are not doing routine endoscopy or systematic PV imaging. Put those together, and I think the right take-home is nanosecond PFA is a legitimate optimized option for paroxysmal pulmonary vein isolation. The value proposition is plausibly workflow, speed, and sedation flexibility more than a giant leap in rhythm outcomes. And that leads perfectly into our next study because it's basically the next attempt at solving the durability problem. The trial is PULSAR, an FDA IDE pivotal program using the Globe spherical array catheter. The idea is to integrate high-density electrodes plus contact assessment, both dynamic and static, and then tailor which electrodes deliver lesions, aiming for contiguous antral coverage that translates into more durable PVI. Let's unpack PULSAR, because it's very representative of the modern IDE philosophy. Single arm, performance goal framework with a composite effectiveness endpoint that tries to capture what we actually care about in clinic. The study was multi-center and prospective. Total enrollment was 183 patients, 19 were roll-in, and 164 were the pivotal cohort used for the primary endpoint analyses. The population here was paroxysmal AF, undergoing pulmonary vein isolation with the Globe PF system spherical array catheter. Now, the effectiveness endpoint was not simply arrhythmia free. To count as a success, a patient had to remain free of AF, atrial flutter, or atrial tachycardia episodes lasting 30 seconds or more through 12 months and avoid other failure modes: acute failure to isolate veins, repeat ablation or cardioversion, and new or increased doses of class 1 or class 3 antiarrhythmics. So it's clinically sensible, but it's also stricter than many pure rhythm-only definitions. How did they look for recurrence? Intermittent but structured. Weekly trans-telephonic monitoring plus symptom-triggered transmissions, 24-hour Holters at 6 and 12 months, and 12-lead EKGs at 3, 6, and 12 months. Again, good surveillance but not continuous implantable monitoring. Acute performance looks strong. They achieved acute pulmonary vein isolation, and most veins, around 94%, were isolated with the first pulsed field application. The whole single catheter, render, and ablate concept is aimed at workflow efficiency, and that efficiency showed up in their procedural time metrics as well. Safety was the standout. The primary safety event rate in the pivotal cohort was about 0.6%, one event out of 164. The one-sided upper 95% confidence bound was around 3.4%, which stayed below the pre-specified safety performance goal of 14%. The single primary safety event was a hemorrhagic stroke identified immediately post-procedure in a patient with major comorbidity risk. And the composite primary effectiveness success at 12 months was about 77.8%, with the lower confidence bound still well above the pre-specified efficacy performance goal of 50%. But remember what failure means in a composite endpoint. It's a blend of rhythm recurrence and management events like redo and drug escalation. Durability, the thing everybody really wants, was assessed with invasive remapping only in clinically indicated redo procedures, reporting per vein durability in those who returned. That's valuable, but it's not a universal remap cohort. So it informs, but it doesn't fully settle the durability question. Now, I want to step back and answer the question that comes up every time we talk about these trials. If PFA is so much safer, why doesn't it dramatically improve efficacy? The honest answer is that the early enthusiasm around PFA was always driven more by safety than by a promise of cure. Across first-in-human studies, randomized trials, and real-world registries, PFA has repeatedly shown a uniquely favorable safety profile, especially the near elimination of catastrophic thermal complications like atrioesophageal fistula and a reduction in collateral injury to structures like the phrenic nerve. That safety signal has replicated across platforms and geographies, which is why the field embraced it so quickly. But, and this matters, adoption has also revealed rare PFA-specific issues, things like coronary vasospasm, transient ST segment changes, and concerns around microembolization. They're uncommon, but they're a reminder that no ablation technology is biologically inert. When you shift the energy source, you often shift the complication spectrum rather than abolish it. The bigger story, though, is efficacy. When you look across trials, freedom from recurrent atrial arrhythmia is remarkably similar between PFA and contemporary thermal ablation. And that looks less like a catheter problem and more like a disease problem. In other words, we may be hitting a biologic ceiling. Atrial fibrillation is not purely a pulmonary vein phenomenon. It's a progressive atrial cardiomyopathy. Fibrosis, atrial dilation, adipose infiltration, inflammation, autonomic imbalance, genetic susceptibility, the whole ecosystem. So if the sustaining mechanisms extend beyond the pulmonary veins, then making pulmonary vein isolation safer and more elegant, however impressive, should not automatically produce a step change in long-term success. Seen through that lens, the value proposition of PFA becomes clearer and, frankly, more honest. The principal advantages based on current evidence are safety and speed, rapid lesion delivery, simplified workflows, shorter procedure times, and reduced anesthesia burden. That translates into higher lab throughput and the ability to offer ablation more broadly, with greater operator confidence. So PFA may not cure more patients per procedure, but it enables safer, scalable, high-volume AF care, is potentially allowing earlier intervention in the disease course and better access. Whether the next gain in efficacy comes from substrate-directed strategies, upstream risk factor modification, biologic or metabolic therapies, or artificial intelligence-guided patient selection is an open question. What is increasingly clear is that the next leap will not come from faster pulses or newer catheters alone, but from a deeper understanding of why ablation fails in the first place. All right, let's land the plane. In part 1 of this series, we lived in the engineering, waveforms, pulse trains, field strength, tissue selectivity, and why electroporation behaves so differently from thermal energy. The core message there was that PFA changes the risk profile by design. In part 2, we shifted to the pivotal evidence, the real-world question of what happens when you put these systems into everyday clinical practice and follow patients out to a year. Across the platforms, the themes repeat. Acute PVI is almost universally excellent, safety is meaningfully improved for the classic catastrophic complications, and efficacy, especially in more advanced substrate, still looks like it's governed by the underlying biology of atrial fibrillation. If you want the numbers, the tables, and the visual comparisons, I'm posting an abridged version with graphs and infographics on LinkedIn. And the full detailed newsletter write-up is available at epedge.substack.com, and I genuinely like to hear from you. If you have questions, suggestions, or you want me to clarify a specific trial methodology or monitoring strategy, email me at epedgecast@gmail.com. Thank you for listening and for being part of the EP Edge community. Bye for now, and I'll see you in part 3.